There you go. Magandang hapon po sa inyong lahat. Salamat for letting me guest speak today. I just wanted to acknowledge my background. I was born in Davao City, Mindanao, Philippines. My dad, Lord Isnick Sr., is from Lumba, Dingras, Ilocos Norte. He's Ilocano. And my mom, who you see here, is from Carmen Bohol. She's Visayan, so my family's from the land of the Chocolate Hills, so the picture you see here. And a lot of what I'm talking about is from my experience with my mom, who has a very thick accent. And before she passed away, she was confined to a wheelchair and also was using a cane. So a lot of the things she has experienced, I've also experienced being her caretaker. And I wanted to be a doctor at one point, but because of all her bad experiences, I'm like, I'll just go to public health but I'm glad the profession I picked now. But anyway, thank you for having me here. I'm also a researcher at the Office of Public Health Studies. I have 20 years of research experience, mostly in community-based participatory research, specifically with Native Hawaiian, Pacific Islander, and Filipino populations. I currently reside in Waihawa, Hawaii, where I'm a settler and I'm occupying land of the Kanaka Oiwi in the Kingdom of Hawaii. Before I start, I wanted to just ask you to take breaks if my content is triggering. So safety first, I'm going to talk about racism, oppression, and discrimination. A lot of that affects our health and access to healthcare, especially in the Filipino community. A little bit background about the Philippines. I know some of you are Filipinos, so just a little brief background. In the archipelago, we have 7,000 islands. We have 3 regions: Luzon, Visayas, and Mindanao. There's around 100 million Filipinos there, and we have a long history of colonization, which affects our behavior, how we see ourselves and how we treat ourselves and how we treat others here in the United States. But we've been colonized by the Spanish, Americans, Japanese. So we have over 500 years of colonization experiences. We also have, because we have so many islands, we have many languages. We have about 171 living languages. A lot are becoming extinct or dying. And the national and official language of the Philippines is Tagalog, along with English. So when you experience patients, you can't just send in an Ilocano interpreter or translator, because not all Filipinos understand Ilocano. So you have to make sure there's a concordance of speakers when you're bringing in someone to translate. So speaking of Filipinos in Hawaii, we're the 2nd largest population, and there's mixed, you can look at 2 different percentages. 26% is if you look at Filipinos and Filipino mixed with other ethnicities, we're 26%. If you just look at Filipinos alone, we're 16%. And we came into Hawaii with the 15 Sakatas, or plantation workers, in 1906. And we eventually came for military, hotel and retail service jobs. And there's a lot of us working in those industries. The diaspora here in Hawaii is mostly of Ilocanos, and we also have Visayan and Tagalog. The person you see in the picture is my dad. So we immigrated here because he was recruited by a pineapple plantation company. So he worked very hard for us. So now when we talk about healthcare and the healthcare we provide, we also want to address racism. And I'm sure you all are well aware of what's going on currently in what's in the United States regarding racism towards Asians. And we're being blamed for the coronavirus. We're being robbed, assaulted, murdered, and it's really taking a toll on us. And it's really such a heartache for us, because they're attacking our elders, which we revere and want to make sure, and they're our backbone for our culture. So we want to make sure we protect them. But there's a long history of racism and oppression towards Asians in the United States. And when you talk about health, racial discrimination has a direct correlation on health. So when you look at this chart that was made by Institute of Medicine, you look at 2 different types here, the non-minority and the minority, who are getting access or getting quality of healthcare. And if you notice in the two bars, the non-minority will have better quality of healthcare. And the difference is because of these items. You know, patients might have different preferences. They have to navigate through the healthcare system. There's so much bureaucracy in the forms. It's not in our language. It's hard to navigate through the hospitals or getting to a clinic, and there's discrimination and biases. It also involves invisible forces that compose of disparities, and that's what the category you see on the right. So sometimes, you know, there's just different cultures that are molded to work for certain cultures more than other cultures. So now I'm going to talk about racism towards Filipinos. And the pictures I'm going to show you are from signs that were put up when Filipinos were coming forward to help with the agriculture businesses. And these are the signs that you saw in California. So, you know, because we are laborers, we became economic scapegoats. We get discriminated on because of our accent. And because of that, we also have limited access to healthcare. Not many of us pursue higher education. And because we don't, a lot of us are not well educated or go to graduate school, our career advancement is very limited. And because of all that racism, a lot of us are exposed to microaggressions and will lead to chronic stress. And what doesn't help us is, it happens more so on the federal level and also on the continent, is that a lot of us get nested into Asian categories, which makes us invisible. And as a response to a lot of discrimination, we as Filipinos internalize it. So we can say, for example, like, oh, of course I didn't get that job because they didn't understand my accent, so it's my fault that I have an accent and they gave it to a white person. So we sort of internalized these aspects. It's like also called internalized racism. And Filipinos, we have so much pride. You know, if something is hurtful or we feel unwelcome, we try to avoid that place. And usually when you think of medical institutions, education, you don't see us there because we try to avoid things that we're uncomfortable with or not, where we're not represented or we're not used to. So keep that in mind when you are facing Filipino patients. I'm sure you all know about the health disparities Filipinos face. We have high rates of stroke, diabetes, and we also have high rates of different types of different types of cancer, including colorectal cancer and thyroid cancer. And I think a lot of it is because we are not eating our traditional diet. So our traditional diet is, we were farmers and fishing people in the Philippines, but we are eating McDonald's here or Golden Coin or, you know, Jollibee. But our traditional diet are vegetables, fish, and whole grains. We're very collectivistic. We don't have any gender-specific pronouns, so sometimes you get mistaken by an elder. They're calling you he if you're a female. But we do have we. So, I mean, we're very collectivistic. If you're older than us, we say manang, manong, kuya, tata, nana. And then this is very important. Behaviors that's related or connected to our culture is called ethnocultural identity. Bayanihan is a translation, is a Filipino word for kinship and camaraderie. And it's always the good of members must take precedence over the individual. And family is our source of identity. So that's why if we move away from the Philippines, we would send home balikbayan boxes. When we go on trips and come back, we'll have pasalubong of knickknacks of where we traveled to. 90% of Catholics are Filipino, so we're very religious, and we love parties. We love to make food, and so especially the pandemic is very hard for us. The picture you see here is the literal translation of bayanihan. In the Philippines, if you're in the direct pathway of a flooding or a storm is coming, your neighbors and villagers would come and help you move, like physically move your home to a safer place or to higher ground. So I love this because this shows prevention at, you know, on this level. So Filipinos are into prevention. So I want to talk briefly about COVID-19 and Filipinos. You know, we're second in cases, and currently right now we're number one in mortality rates with the coronavirus and the pandemic. And last year we started seeing news stories about Filipino Americans being hardest hit. And then so we waited for a while. We're like, let the government help us, let there be services for us, but no one really came. So what we did was we gathered a lot of Filipino kababayan, our friends, stakeholders, leaders in our community, PMAH, community health centers, Filipino Catholic Club, and we went for CARES funding, and we came up with the Philcom's CARES project, and collectively, it was a community response. And we got funding from the Legal Clinic, Department of Health, Hawaii Public Health Institute. And we started putting together translated materials in Ilocano and Tagalog. I helped make these flyers and materials because we distributed in clinics, in hospitals, community health centers, even at Catholic churches, at schools, and they are vetted through our community, Filipino community. So there's Ilocano and Tagalog, and we made a website so that they could access it. And through Philcom's CARES project, we actually went out to the Catholic churches to do the COVID testing, and we're doing vaccination clinics because 90% of Catholics are Filipinos. And we helped distribute materials. We recruited individuals to volunteer. So when you go to the Catholic church to get vaccinated, you are welcomed by people you can relate to. We will welcome you in Ilocano, Tagalog, and we'll help answer your questions. So we make it a little bit more welcoming, especially for those who are scared of the system or uncomfortable. So regarding approaching Filipino patients, it always helps to be linguistically and culturally appropriate. Linguistically means it should be in Ilocano or Tagalog. Culturally appropriate materials. So we always know if we're getting something from the mainland or the continent, right? It doesn't show us. So it's helpful if it was made in Hawaii. Materials, items you're gonna give to patients. And if you're speaking in English, make sure you have translators. That I know not everybody has that luxury to have translators, but it'll help to have Ilocano, Tagalog, Visayan translators. Materials in our language. Currently there's like different diabetes materials also you can have access to, and cancer materials. And family members, have family members present just to be supportive, and they could actually bring home the information to share with other family members. Family members are not translators because they could omit or add things that are not meant to be shared with the patient. So make sure you include the family members because we're collectivistic. Family is important to us. Speak slowly, eye contact, limited touching. That's fine. You know, just like the Hawaiian community culture, the Hawaiian culture, we do have our form of mana. So please try not to touch the patients unless you're examining them, but proceed with instructions. And access, understand their accessibility situation. If they have access to materials, medication, food. Telehealth is hard for our nanas and tatas. They don't have internet sometimes. They don't have electronic devices. A lot of times nanas and tatas love being face-to-face. So when we do COVID testing or COVID vaccination, we actually register our nanas and tatas in person. They feel more, they could trust you if you're in person rather than the internet because of all the scams and whatnot. So make sure if you can, it's better to deliver news or talk to them in person. Transportation, Filipinos are #1 in using the bus in the States. So if they are using the bus, make sure it's in the bus line, x-rays, prescriptions, whatnot. I did a study on HPV vaccination and barriers and motivators. And the #1 was for them to vaccinate their child, the #1 motivator, lo and behold, for Filipinos are physician recommendation and also materials from the doctor. So physicians are a top source and motivator of HPV vaccination information for Filipinos. And it is true across the board in any other vaccinations and other materials. So imagine HPV sometimes has some stigma to it. If we can come across and have them vaccinated with the HPV vaccine for their children, imagine other things. So please think about that and recommend from your mouth and have materials for them to help push for your message, your health messages. And then practice humility. They're there also to teach you something about their community, about their culture, understand the history. All of this come into place: mistrust of the medical community, discrimination, lack of representation. Patients listen and respect you. So, and also utilize materials, family, and community. If you don't know, please ask. There's many of us who can tell you what to do. The Filipino community, where to refer you to translating materials, translators, and whatnot. Know that we're collectivistic. Use the community to your advantage. Have the family work with you. And then, you know, the medical organizations, it's not made for us here for Filipinos. You know, it could be a system of oppression. So you want to make sure it's integrating a lot of the different cultures instead of asking us to be resilient all the time. So I'm just listing resources here, and I'm running out of time. Philcom Cares has a lot of translated materials for COVID-19 that I helped create and that we're promoting. Department of Health has a lot of diabetes, physical activity, COVID-19 materials. I used to be with Palalay with Imihale, worked with Dr. Palalay on the cancer patient navigation program. But even though we don't have translated materials regarding cancer and diabetes, we have the right brochures and education materials that is a good health literacy level to use with patients. Maraming daghang salamat, agyamanak unay. Thank you so much for having me here. And that is it. Thank you.
That was a great talk, Dr. Dela Cruz. So now we're gonna go ahead and transition to a little medical Ilocano lesson. I've included a handout in the chat, so you can go ahead and download that so you can follow along.
Okay, can you guys see my screen? Can you see my screen?
Yeah.
Yeah, okay. So good evening, everybody. I'm Dr. Hazel Abinsay, one of the Philippine Medical Association of Hawaii mentorship chairs. My husband and I, Dr. Mark Valdez, we apologize for our son in the background. We were both born and raised in Hawaii, but both our parents are immigrants from the Philippines. We're both Ilocano. So we just quickly put this video together. It's on YouTube so that later on you can go back if you ever have that Filipino patient and you needed to refer to a video that has these words and you can listen to them how they're pronounced. It's on YouTube. I'll have the team email you the link. And then there's also the handout. So here we go. Enjoy. It was 4 minutes and we apologize for the noise in the back. That was our niece. Good evening, everyone. I'm Dr. Hazel Abinsay.
And I'm Dr. Mark Valdez.
If you want to learn how to get a good history from your Filipino patient, this might not be the video for you.
But what we can do is help you get a basic history while you wait for your Filipino interpreter to come and save your ubit.
First things first, there are many dialects in the Philippines. When you hear the language Filipino, that usually means the national language of Tagalog.
Tagalog speakers usually are from the capital of Manila, so they usually also understand English.
However, many Filipinos in Hawaii are natives of the northern part of the Philippines called the Ilocos region, where they speak Ilocano. And that is what we will be teaching you today.
Just a couple of disclaimers. We are definitely not fluent in Ilocano.
But we are very good at broken Ilocano.
Which is just enough for your purposes. Your grammar may be wrong, but the message should get across, and the interpreter can clear up the air when they arrive.
And Filipinos are always thankful that you even try to speak their language.
First of all, greetings. Filipinos are very respectful in their speech, So they always refer to their elders with either manong for older male,
manang for an older female,
tata for elderly male.
and nana for an elderly female.
An easy way to introduce yourself to say, "Hi, my name is blank. I am a medical student."
Kumusta ka, nana? Siak ni, insert your name. Siak ti, medical student.
Most of the time you'll get an okay as a response. Filipinos tend not to complain a lot. But if they start responding with their chief complaint, listen for some of these common words you might hear, and it will help you focus your history taking. Pain,
Sakit,
dizzy,
maulaw,
tired or fatigued,
nabanog,
cough,
uyek,
runny nose,
panateng,
shortness of breath,
narigat ti angis,
vomit,
sarwa,
diarrhea,
diarrhea,
itchy,
nagatil,
fever,
gurigor. Body parts, head,
ulo,
eyes,
mata,
nose,
ogong,
mouth,
ngiwan,
neck,
tengen,
ears,
lapayag,
throat,
karabuko,
chest,
barukong,
abdomen or stomach,
tiyan or buksit,
back,
bukot,
hands,
hima,
legs.
saka. To ask if you have pain in a certain body part, you say, "Sakit ti,"
So for example, headache,
"Sakit ti ulo,"
chest pain,
"Sakit ti barukong,"
abdominal pain.
"Sakit ti tiyan,"
To ask simply if they have something, say, adati blank mo, medicine,
"Andat ti agas mo,"
allergies,
"Andat ti allergies mo,"
hypertension,
"Andat ti high blood mo,"
diabetes,
"Andat ti diabetes mo,"
cholesterol.
"Andat ti cholesterol mo,"
They may answer with a yes or a no, which are yes
"When,"
and no.
"Haan."
And lastly, thank you in Ilocano is agyamanak.
And don't forget terms of respect.
We hope this at least gets you started in your history taking.
Remember to use a translator when in doubt, and remember to be respectful.
Agyamanak. Okay, everybody, that's our video. We'll have that uploaded and shared with you folks. If there's any other terms that you feel like are important to you that you want to learn, just go ahead and shoot us a DM or a message.
All right, that was awesome. And I'm definitely gonna refer to that if I have a Filipino standardized patient, just to throw them off. So we're gonna go on to the panel right now. And so just so for our speakers, just feel free to kind of, like speak up and just kind of popcorn it. There's really no order to this, but the first topic that students wanted to talk about was culture and healthcare attitudes in Filipino patients. So if you have any insight to share on those things, please fire away.
I can share something. When I first came back from the mainland, it had been, like 14 years, in continental US. And one of the first talks that I participated in through the Philippine Medical Association was at a CME. And I remember Dr. Ponce, he's a psychiatrist here in town, talked about the Philippine attitude, cultural attitudes towards sickness and illness. And I think his talk was mainly about depression. But he used a term called bahala na. And it's sort of this inevitability of illness, I think, is how it's described, that we're sort of predestined. Whatever happens is sort of predestined. And I think for me in the oncology world, sometimes that's an element that's kind of an obstacle or a barrier to effective therapy, because You know, if people feel like, well, this was inevitable, this was, you know, going to happen, and whatever interventions we have, you know, it won't matter because I was meant to have cancer and I'm going to die from cancer. So, so that was, you know, a conceptual thing early on that I learned about, and but in real life and in practice, I've actually seen it manifest. So it's one of those, you know, things that I think, you know, we as healthcare providers are always going to have to address, you know, that no, it's not inevitable that we can make differences, and we can have meaningful interventions in terms of trying to change sort of the natural course of a diagnosis or a specific illness. So that's my kind of thing I wanted to share with people. I don't know, Gary, you want to say something about that? Or?
Yeah. You know, kind of what Dr. Palalay was saying, you know, that bahala na attitude, like it's predestined, like it's kind of like what else is there to do? What I'm realizing is that, you know, as important as this pandemic has shown us, there's a lot of stress on mental health, right? And even before pandemic started, you know, there would be a new, not so much a new surge, but a new importance placed upon finding our patients. And I'm speaking primarily as a pediatrician in this sense, okay? What we've been doing for the past, I would say 5 years, is starting to screen more for signs of anxiety and signs of depression in adolescents as early as 12 years old. And what we've discovered before pandemic was that its existence was primarily denied by a lot of our patients' parents, whether that be a refusal to understand what mental health was, whether it be a complete defiance of depression as a symptom or a sign or as a diagnosis. It just didn't gel well with Filipino parents. So that attitude of, I'm just not going to do anything about it, it resulted in a lot of young children. When I say children, I mean 12 and 13 who were supposed to screen. They didn't get the care they needed, basically because it wasn't because there were a lack of resources. There are, in fact, a lot of resources. It's just that the parents wouldn't believe you. So you know, with a Filipino family, especially a Filipino parent, you're not supposed to be depressed. You're not supposed to be nervous. You're supposed to hide your feelings and keep it in your stomach and tie it in a knot and throw it away the key, and that's it. But I'm finding now that as long as, you know, everything that Mayor Rose was talking about, you know, it's a different way to speak to the parents. You know, it's a different culture, so you have to understand where they're coming from. You don't just not listen to them because their attitudes are wrong. You just have to find a way to get through to them and say, look, I'm not here to tell you something's wrong with your daughter. or your son. I'm just here to tell them that I can help. And you just kind of have to work with them. And, you know, with Filipino parents, it's not going to work the first time. You have to keep calling them maybe the following week. And the best thing that, I guess the best thing that pandemic has taught us, that we're doing a lot of telehealth. And it's very easy to get on a video call, or it's very easy to get on a phone and just call them and say and follow up. And, you know, if you do that, it'll show the parents that you actually kind of care. And I think being persistent without being bothersome will actually go a long way in terms of telling the parents, the Filipino parents, how you really care about their child. By the way, Hazel, all that 5-minute lecture was about 2 years ago. We were supposed to have a lecturer at one of our conferences. He was given a full hour. And I don't remember anything from that 1 hour lecture. I'll remember like 20 things from your like 4-minute video. Easy. So we're having you next time for our speaker at the next conference, okay?
Ilocano 101.
Ilocano 101.
I think I wanted to add regarding the Filipinos is that a lot of, in the Filipino culture, there's this sense of we don't want to bother people. We don't want to seem like we're intruding or being bothersome. So a lot of times, what I find is when you have a Filipino patient is if you're explaining something that can seem a little bit more complicated or requires multiple steps, like please make sure that you go do this and then this, et cetera, et cetera. And then you ask them like, is okay? And then they say, yeah, okay. But they have this look of like, I'm lost and I'm confused. They're not gonna ask you to repeat yourself, or they're not gonna question you. They're gonna say like, okay, doc, yes, doc. And then they're gonna leave and then feel at lost because they don't wanna bother you. So if ever you're in a room with a Filipino patient, one of the biggest things I wanna pass on to you is if you have a patient that you feel like your message is not coming across, and you can feel that, feel free to just like, manang, I know this is a little bit more difficult, but please, it's okay to ask me questions or get that translator in. Even if they feel like you're communicating in your Taglish, Ilocano, English, if you think you're communicating, but you think you're giving a message, but it's not being received, please be careful because so much can get lost in translation. And that's so important in medicine. That's it.
I know I'm not a panel speaker, but I can add something.
Who are you?
Hi, everybody. I'm Dr. Morel Ver. I'm president of the PMAH right now, but I'm also a surgeon. So talking about, Dr. Palalay had discussed about the bahala na, So I get referred a lot. I mean, I'm a surgeon. I get referred patients for surgery. And when patients come in my office, they're scared because they don't know what to expect, or it's like surgery, right? And oftentimes, when I get referred patients, it's a positive screening test. So meaning they don't feel a lump in their breast, but the mammogram is positive and there's cancer, or their colonoscopy says there's cancer, right? In the Filipino patient's eyes, if I have no pain, I still can work and it doesn't bother my day, it doesn't exist, right? When we're taught in medical school, okay, we have to do the screening thing, detect it early and do their surgery early. So in my encounters with patients, I talk about, I kind of go talk about why the screening test is important and why they're sent to me. And half of the time they will, go for surgery, and half the time it's like, it doesn't bother me. We'll just watch, and if you have a patient who doesn't want any intervention at that time, I think it's important to make a deal with them. So it took me a year for at least 3 of my patients who diagnosed early colon cancer to get surgery. So I would see them every 3 months saying, okay, let's see how you're doing. Let's hear, are you bleeding? Do you have pain? And then every time I go, if we have bleeding, if you have pain, we should consider surgery. It may take me a year to get them to surgery, but I'll get them there. And because there's a relationship there, the idea of, okay, she's just trying to help me. And on paper, I mean, I didn't abandon the patient and I'm doing the right thing, right? So again, it's about being persistent and coming up with a negotiation plan that works for both of you, and documenting it in your note that patient declined, but this is what we're going to do right now. So especially in this world where you guys, they're looking at your notes and all this kind of stuff, the documentation of them not really refusing, but declining care at this time is very appropriate. That's my 2 cents. Thank you.
But don't you feel, Morel, that a lot of times the reason why they decline doing anything is because of the socioeconomic stressors that they're having at home? Because if they go through surgery, they know that they're going to be out of work for a certain amount of time, right? And for many of them, a lot of our patients are immigrants and they're working 2 jobs, sometimes 3 jobs, and their income is really vital for the survival of the family. So to know that they're going to be out of work, they would rather work with cancer, rather not be able to earn money to feed and pay for the homes of their families. So that's another message we want to share with all of you, that sometimes when a Filipino patient might not choose to go down the recommended route, it's because they're worried about their families. And like Dr. Mayrose said, We're very family oriented. We will put families first before our own health.
And that's why it's good if you can have another family member having these difficult conversations. Because I ask my patients, why don't you want surgery? No one's gonna water my plants. I'm like, no, your family can water your plants. You know, it can be something as little as that to something like, I cannot work, I have to support, blah, 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 blah. But again, your negotiation is, okay, when you find somebody to cover this, or when you have time with your boss, come back and, you know, we'll discuss it. But if you give them those expectations and kind of the parameters you work that need to happen, and a family member's also hearing what needs to happen, because again, the family member wants to help the situation, then I think you'll move forward in your plan overall.
I learned early on, you guys, that, you know, there is this, I know Carolina wants to say something too, so I'll be short. But I learned, you know, that, gosh, you really can't look at the Filipino community as this kind of monolith. You know, you can have like this like amazingly educated, you know, this wide range of like, you know, very sophisticated intellectual academic people and very smart people. And then you can get a group that may not be as advanced. And, you know, I learned early on trying to recognize kind of that level of understanding. And I think that's a basic concept, you guys. I mean, we in Hawaii have all these different cultures. The Filipinos are just one of many different cultures that we encounter, you know, and the barrier of language and culture is always there. But I really learned early on that, boy, you know, understanding or appreciating the level of understanding, you know, is so important. And I worry a lot about, you know, having these complex discussions about, I don't know, like illness, or like, you know, whether to do an ERCP on someone, or, you know, whatever, you know, these complex medical issues, and having these limited kind of understanding. And I really feel for my Ilocano or, you know, Tagalog patients, mainly Ilocano though, whereby I don't sometimes know if there's that level of academic sophistication to understand what's being proposed. And you know, really got to take it, you know, with a very delicate, you know, kind of approach. And like what Dr. Ver was saying, you know, maybe we're not going to answer the question or make the decisions in one fell swoop, but maybe it's going to, you know, you're going to have to take time and, you know, bring in individuals. I do find that my Filipino patients are, the family units are really strong. And I'm always impressed, like, you know, like having like a daughter-in-law, like assume like the care of, you know, the father-in-law. I'm like, wow, I don't see that a lot. You know, it's like a like, well, family member, but not like the actual daughter, but they're taking care of their elder with the same, you know, dedicatedness and the same kind of passion that you would see in a like a blood member of the family and things. So I'm always impressed by that the family units are tight, and that's what I try to look at is, you know, identify the champion in the family, and then kind of use use, you know, that person to really communicate through. Because I mean, at the end of the day, you know, when we're talking about serious illnesses, I mean, everybody wants the best care and wants the best, you know, people, and wants the best advice. And you know, sometimes when in the rushed setting of clinical medicine, you know, those things get kind of tossed aside. And anyway, Carolina, Dr. Davide.
Hello. Yes, I'm a solo practitioner out of YNI. So, and I'm a native speaker, and I could talk Tagalog and Cebuano. So, first of all, we have to think, what is the Filipino patient? So it could be like, if they're immigrants, like me, an immigrant, you have to determine how long they have been here. Because sometimes the one who just came from the Philippines has a different mindset as compared to those who have stayed here for a longer period of time. So they have evolved in a way. So we have to approach that one. And then the next thing is like, there's the next generation who are taking care of the migrant parents. So you have to put that into consideration. So usually like those who are, let's say 1 to 2 years here, they haven't adapted to the culture here. So they have this certain like uh, how they are in the Philippines. So you have to consider what they have been eating, and you could notice that they would ask you a lot of vitamins, like, because we have to consider like in the Philippines, as a part of the problem is like the nutrition. So depending on what socioeconomic status they came from the Philippines, they would ask here, like you would ask like, Doc, what is the best vitamins for me? So what I noticed too, there I had an aha moment when I was starting to take vitamin D levels. If their vitamin D levels are low, and then you give them the vitamin D, then they think, and they feel much better. I said, oh, maybe that's part of it. So aside from telling them to eat the vegetables, which they seldom eat because it's not convenient or the cost is more expensive. So that's why they would take the vitamins. So that's where, so my next thing was about the provider, about the screening procedures. I just tell them, because number one, my approach to the Filipinos, primarily I know they're all providers. So they would have 2 jobs, or they would have jobs to support family in the Philippines, depending on what type they are. Like there are some that, like me, I don't have to support people in the Philippines, but there will be others who will be supporting. So it depends on how to approach them. So when it deals with the screening for colorectal and for the other cancer screening, what I tell them is, if you have this cancer or if you don't take care of it at an early part, you might not have a job, or you cannot pay even the copay. So it's much better for the prevention. So that's what I tell them. And I make sure to tell them, if you don't do this, this will be the consequences. At least they would know we did our part explaining and why it is important. And so if you don't do this and it comes late already, then you have to pay a higher copay, then you cannot work as efficiently, or you'll take more time off to take care of yourself. So it would be difficult to paying that copay that occurred. And then the next part is mental health. Yes, there are a lot of depressed people, especially now that if they're out of their jobs or they cannot provide for their family in the Philippines. And so what I tell, especially parents who have, especially the new ones who were here, and I tell, when I was covering for some pediatricians when I first came over, and I have to screen kids from the Philippines, I have to tell them the expectation: you are here now in Hawaii, people would be teasing you, they will be bullying you because you look different, you talk differently. But if anything, if it occurs, make sure you tell someone. It's not like they call it hiya, nahihiya ako, or I'm ashamed, or I don't want to bother, but you have to, because if you don't take care of it, then you will become depressed. And the complications, or the worst thing that could happen, will be suicide. And so I tell about the suicide as a complication to the parents. And of course, no one wants their kid to die before them. So that's just my approach. Wow, quiet.
So you left off on a very heavy subject, I guess. And yeah, I do think that deep down, Filipinos do kind of have, even if they do kind of have like a fatalistic view of their health, if you do put the consequences in front of them, they do listen to you, at least in my experience, my short time on this earth. But I guess in this theme of what kind of drives a Filipino patient to make their decisions, I have a question here that was submitted ahead of time, and it goes, how do you respond to a patient saying, we're people of faith, I trust what you're saying, but I believe God grants miracles? How do you respond to that when having a goals of care discussion with the family for a patient who has a poor prognosis? How do you kind of address this? I don't know if I'm pronouncing this correctly, makadios, kind of, I guess, like view on life, like the faith in the Almighty. If any of you could address that.
Yeah, so, as an oncologist, I think a lot of people think doom and gloom, and we do have, a lot of challenging cases. Pancreatic cancer, for instance, is really tough. I think for me personally, it helps that I do come from, kind of that persuasion as well. I was born Catholic and, haven't really swayed far away from that Catholic tradition. And that's important because, the Filipino community is like 90%, like that country is like 90% Christian or Catholic, and there is a very, very strong, adherence to that Catholic tradition. The way I, approach that, Austin, is, I always, say that I share, similar feelings in terms of that, but think of, the providers as, and the people around you as sort of manifestations of God, in that setting, that we are, working through, that higher power, and the messages that we give you, may be coming from that, and that's kind of how I've approached it, in a lot of ways. That God, I'm, or whatever being that you believe in, it is sort of working through, the people within your sphere, your health team or that, and I try to appeal along those lines. And I think that's an important question because there's a lot of sort of magicness that people kind of believe in the Filipino community as well. So there's a lot of traditional healers in our community as well that are there. People in our communities know who these people are. In every community on Oahu and neighbor islands, if you ask people, like, who are the healers within this community, there are people that are not necessarily Western trained, that influence how people approach their health. And so I think it's important to acknowledge that there are people out there. So there's sort of that religious basis of it, but then there's this whole complementary alternative healthcare piece that's important, and these healers that are out there in the community exert a lot of influence as well. So I think you have to acknowledge that they're out there and that they can affect how people make their health decisions as well. So I don't know if the other guys in the community want to mention that, but I've seen it. I've seen people refuse evidence-based medicines and approaches and go that route. And not just Filipinos, but I do see it, especially in the Filipino community.
Dr. DeVita, you wanted to say something?
So when a patient approach me, and that's approach, I tell them, physicians are God's instrument of healing. And second of all, so if you take it at that note, we are here to help you in the process. Everyone dies, I tell them. Everyone dies. When and how, we don't know. And the Bible even says, only the Father knows the time. So I emphasize that on the patient. And second of all, I tell them that our bodies are the temples which the Lord created. So you have to take care of your bodies. So that includes also the commandment they say, thou shalt not kill. Thou shalt not kill yourself by eating whatever. So you have to be careful to what you feed yourself. So that's how I tell my patients. So if they say, we will pray that there will be a miracle, I said, remember, every one of us dies. What do you mean by a miracle? Is the miracle in your heart that you want peace, or a miracle to get better or have longer lives? But if we know that your life will be shortened because of certain risk factors or the cancer, just prepare for the end, we tell them. And part of telling them the end is to buy a funeral plan so you don't be a bother to the whole family. Because if you have no funeral plan and you die on a weekend, it's hard to get one, and they'll offer you everything and you just pay out of pocket. So that's what I explain to my patients. I don't know with the other.
With terminal illness, I am increasingly aware, and for my Filipino patients, some of them have this very strong pull to get back to the homeland. And that's something that I've really recognized, over the course of these last, 15 years, 20 years. And so, that's part of the whole aspect. Sometimes treatments that are non-curative, I mean, there can be these long periods of sustainability and good quality of life. But if we can't guarantee that, they'll be strong enough eventually to go home, that's a big factor, for some of my patients. They go, you know what, I'm gonna go home. And there's this really strong desire to get back to family members that are in the Philippines and whatnot. And I'm certainly increasingly aware of that phenomenon. And it's something that, people will do. I mean, they just, even though, the medical world is more sophisticated here in the US and there's more stuff to do, that sometimes that's not the most important thing. It's really getting home and being with loved ones. And, in oncology, we have to deal with those kind of scenarios a lot. And I'm increasingly aware of that aspect. I don't know, May Rose, I don't know if you want to mention something about that, or maybe in your studies.
Yeah, I think it's important to integrate as much as you can about the culture, what they're eating, and really, push for what do you believe in the Philippines. We talk about abulario, that is very underground because you won't see them in the yellow pages or Google them. It's very quiet and discreet because there's a lot of mana and energy, and they really hone into specific cultural practices. And you cannot disregard that for Filipino communities. You have to integrate that into Westernized medicine. Just bring it up. Do you believe in a healer? How do we integrate my practice with what your belief in? And by including that, you're acknowledging their culture, and I think they'll be more open to Westernized medicine because you're pulling a part of their culture. Maybe you have to do a little bit more homework, but that's part of cultural humility, right? Asking them, what do you believe in? How can I supplement that with Westernized or Americanized medicine? So I think the more you acknowledge it, the better it becomes, but the more you disregard it or omit it, then they're more, opposed to Westernized medicine. So I think we have to really think about the Filipino culture and our approach, because we haven't been doing that really well in our materials and our medicine and how we're acknowledging things, especially with mental health.
I'm gonna butt in again, sorry. I think when you guys are in medical training, it takes a while to learn how to get a feel for people. And when you're dealing with a terminally ill patient or the elder patient, people have different levels of their understanding of their acceptance of when they're gonna die. right? So I've had patients in my clinic with metastatic cancer who don't want chemotherapy, right? And so, and again, they do want to go home to the Philippines, and that's the goal. Well, what you can counsel them, or I counsel them, okay, well, in the meantime, let's make sure you're eating your vegetables, make sure you're taking your vitamins. I want you to pray. I want you to spend time with your family, spend as much time with your family, you know, counsel them on the things that they can do, because you want to try to make it a positive, worth time. And then with these patients, okay, you do have a lung mass. And this is going to grow because you're not getting therapy. But you know, if you're going to have shortness of breath, when you're coughing up blood, if you have pneumonia, then you know it's time. Then you know that's your time. And because they're gonna say, oh, God will take me when I'm ready. But if you give them those, like for me, with my patients, I make a deal with them all the time. But they know what to expect, and they're okay with that. And if their family is in the room, and you tell them what to look for too, then it gives them a sense of, okay, she said this already, it's time, okay, we're ready, because I already brought it up as a possibility. So something to think about when when you find your style with your patients. You don't want to push them off and saying, oh, you don't want treatment, don't see me. You want to recommend stuff that they can do to make the time worthwhile, right? And that's what I think all patients want. They want to make sure you're on their side. They want to make sure you understand them and care about everything else, and not just the medical part, because the everything else for an ethnic patient is a big, big deal.
Okay, yeah, that was all good points. I guess in the same theme, I have another submitted question, and it's, how do you discuss end-of-life care for terminally ill Filipino patients with their family members? And I guess this person, in their experience, Filipino families tend to avoid that discussion, and it ends up negatively affecting their loved ones. You know, for example, like if their loved one is on a ventilator for, you know, long term with no chance of recovering. What is your general approach to that?
Gary, I imagine you're not having a lot of end-of-life discussions with your patients.
Okay.
It's tough. I mean, and again, we can't really, you know, kind of generalize. And there are, you know, in terms of end of life, you know, I see, you know, kind of this, you know, sort of not, you know, kind of this spectrum. It's a very wide latitude. And so there's people who don't want to do interventions, just like what Dr. Vera is saying. And then there's others who go, we want to keep going, doc. This is, you know, we would want that. And so I've seen that on both ends of the spectrum, where it's minimalist and then maximalist interventions. And it's hard, you know, sometimes it is something to be mindful of. And I think we're introducing, you know, we're becoming better, you know, through the decades, I think, in terms of introducing end of life issues and end of life care early on. And we use whatever we can, you know, what people have been talking about, whatever we can do to facilitate the communication, respecting the religious beliefs that a patient and family has is really important, respecting that and having these discussions. And sometimes, I'll be honest with you, sometimes nobody wants to talk about it. Sometimes nobody wants us to even talk to the patient about whatever this diagnosis is. And we have to respect that sometimes. I can see how that you know, we can accept that. Sometimes the family feels very strongly about not telling a patient that they have lung cancer. And so, but trying to get a plan, you know, trying to get an advanced directive or a post in place is really, really important. And I think, you know, again, our Filipino community with that religious basis of Catholicism and Christianity. You know, I've never had a patient of Filipino extraction talk to me about end of life, the medical aid in dying scenario, which since 2019, that's become available for all patients. I've never had one single Filipino family ever talk to me about those kind of scenarios. So what we do have is palliative care issues, and we try to, and fortunately in Hawaii, we have a lot of good palliative care organizations. There's like 4 or 5 of them now, some of them that are, with very key people in there that are of Filipino, background. And we kind of hone in on that as well, especially with our Filipino language, patients as well. So, I do incorporate the palliative care piece really early on in terms of that discussion.
Hey, Dr. Palalay. So I'm in the ICU, so I really greatly appreciate when you guys start those conversations in your office, and I'm not starting them when they're like, on 5 pressors on the ventilator and just like ready to die. So I always struggle with this. Like, I've been doing this for years, and every time I have to bring up this discussion, especially to a Filipino family who are so strong. Thank you. She's letting me sit now. So yeah, so I always struggle when especially when the family is so strong in their faith. And I'm a person of faith too. So I struggle because then, yes, there are miracles based on what I believe, but at the same time, I also believe in what I was taught, where, a pressure of 50/10 is not compatible with life, and they're going to die, and regardless of what I do. I think the worst thing you can do is, and I think everyone's already kind of alluding to this, but the worst thing you can do is try to break down their faith, try to go against it and try to break it down and say, like, look, God doesn't exist. Science tells me that this person is like 99+% gonna pass. Like, doing that is going to be such a disservice, because they're automatically not going to trust anything you say after that. So try not to go against their faith, I think, is one of the big things that I do. To try and incorporate their faith, I always think my go-to is always like, maybe God wants him to come, and because medicine is so good, we're stopping that from happening. Maybe God is wanting him to come, and we're just preventing it from happening. Maybe that's what's going on here. Like, God is calling him already, and maybe God is sending me to tell you, hey, we need to stop doing what we're doing. So, I mean, that's pretty much the biggest message that I can send, is just don't clash with their faith, because then you do that, you automatically will lose any sort of trust that you gain. And I've had cases where, like, even though you don't do it, sometimes the family will still like run away. I've had instances where, like, family will disappear on us. Like, we'll call them one day and they answer readily, and then next day it's like, oh, he didn't answer, I'm just going to leave a message. And then the next day it's like, they're still not answering, and they stop visiting. And then that's, I don't know what to do with that, but I usually end up consulting palliative care or social work just to try and get more people, to try and see if we can capture these people, like contact these people, because it's a disservice to the patient who you're really taking care of. But yeah, again, I think my overall message is, do not clash with their faith, because, like I said, they will lose trust in you, and that doesn't help you at all in the long run.
My take on it, I have experience with my father, taking care of my father who had cancer and going through hospice. So I use him like an example. Like, my father, 2 weeks before he died, told me to get a funeral plan and buy it. And so with that, I would tell the patients, okay, because I memorized most of the signs and symptoms, right, Dr. Palalay? That is, their hospice has a book about I call it the blue book. It's about transitioning to their next life and having the symptoms. So if I see like, if they don't want to eat meat, that says around 3 months. If they don't have urination and sleeping a lot, that would be close. So with that in mind, I tell the patients and the families, you know, take these last moments for quality time, and remember it is the quality of life of the patient. The other family members are also, while they don't want to talk to you, is because they don't know how to deal with the loss. So with the anticipatory grief that they have, they don't know how to deal with it. So that's why they don't want to ask questions, or they want to say make the time longer. But then I emphasize to the family members, it is not you that are suffering. They know that they are suffering. The patients know. So also, please tell them what is happening. Like, tell them that they have cancer. In fairness to them, if you don't tell them that how far the cancer would be, or like if they're short of breath or they have heart failure, if you tell them, okay, it is almost near, at least they would prepare for the next life. They would have relationships, like relationships to be repaired, or say goodbyes to all the relatives in the Philippines via FaceTime or via Viber. So give that chance to that patient. But if the patient is in the ICU or cannot talk, then you tell the family members, like, this is the transition to the next life. In the Catholic, because I'm a Catholic too, there's what we call the Catholic, they don't encourage like ventilators, because that is like extraordinary means to extend your life. So extraordinary means. Because when I was in the Philippines, when I did my medicine, medical school there, when we were interns, we would there were no ventilators. So you have the ambo bag and you're ambo bagging, right? For how many hours? And I would pray, so Lord, please get this patient. I'm so dead tired. So you have that guilty feeling, and I would like, I had to go confession. Father, is it a sin to wish death on the patient when I'm so dead tired pumping? Or you do CPR, you hear the ribs cracking? And so he said, no, they are all extraordinary means to extend life. It is okay that it is not a sin that you wish the patient to be dead because of that. But it's already the end of life. So from that, I would explain to the family members, you know, all of us would pass, make it comfortable to that parent. I think, or that patient, I think it is okay to let go. They might have guilty consciences. They weren't taking care of the patient, didn't visit. That's why they want to cling on. But if you keep in mind about the extraordinary means, what will be their quality of life, you just say, let's try and see if without those extraordinary means, if they would be okay or not. So that's what my dad taught me. So, and I'm about the funeral plan, I would tell them, prepare for one. As my dad would say, if the time comes, you just call the funeral plan and funeral parlor, say, he's ready for pickup. So.
You know, kind of just real brief, you know, to that point and to Mark's point, you know, there's such a thing as like capital, you know, like when you invest in like a relationship with a patient, you're investing capital in that relationship, and you're investing trust in there. And even in the sort of acute, you know, kind of chaotic, frenetic setting of an ICU, you can still be able to develop that kind of investment, you know, with patients by, you know, being, you know, empathetic and being respectful, and also listening, you know, to what patients what they're saying. And I think at times, you know, what does the healthcare team want? We don't want to do anybody harm, you know, and sometimes it gets to a point in a futile case where doing more is going to be harmful. And so I've found that at those moments, I've been able to pull, you know, draw that relationship capital that I've developed with a patient and their family, and in a very loving, compassionate way, just say, look, you know, now is the time. You know how much we've gone through and how much we've tried to help, but now may be the time for us to pull back, because I don't want to, you know, do any more harm. You know, I don't want to, you know, make it such. And you know, I would say most of the time, the families are able to process that information, maybe not acutely, but we'll process that information maybe overnight and then come back and say, you know what, you're right. We don't want to harm. We don't want to cause more harm. And I think if one takes sort of that, you know, kind of tact in mind, that we don't have to, you know, proceed with this like, oh my God, we're going to just keep doing everything to do that. And I think if you are able to develop that relationship with a patient and their family, you have, you know, the gravitas to really pull back at that moment in time. And I think for all you young doctors to be and healthcare people, that's an important message, to go in and invest, you know, your time with these patients, whatever kind of specialty you guys go into, whether it's going to be a surgeon, whether it's going to be a primary care, whether it's going to be pediatrics, you know, invest in it, because you guys can impact so many lives based on that relationship. And I think, you know, when I work with the young medical students that are coming through and the residents that are going to graduate, you know, I remind them that, look, in your career, you're going to save lives and you're going to make differences in people's lives. That's just part of what we do. And you know, so take that, you know, what this, you know, this gift of being a physician and the impact you'll have, and take it as, you know, as a sacred trust that you're going to develop. And you know, I think regardless of what you're going, you don't have to be an oncologist, you know, or an ICU guy, like in the intenseness of that. I mean, but there's so much, you know, difference you can make in the world just by investing in it, and investing in the kind of population that you work with, whether it's Filipino or Chinese or African American. You know, you guys should be able to develop those skills and go into whatever community you have and be a difference maker. I think that's probably the biggest message I would want to share with you guys.
And sorry, can I add regarding investment? I'm not a doctor, but I am a prevention researcher. So there, you have to look at it as a generational intervention. So I used to do a lot of organ donation. This is like indirectly affects end of life, right? I used to do a lot of organ donation education because Filipinos are top in dialysis, and you know, not a lot of people were donating organs, especially Filipinos, because of our faith. So I think we have different points in time where we can affect what can happen in the future. And one point of that is organ donation. When you talk to an adolescent who's about to get their driver's license, you can say, do you want to be an organ donor? Or when they're about to get married, you know, there are many points of interventions that you can push so that when they do come to their end of life, they already had that discussion with their family multiple times. And it's not uncomfortable, and you have to decide for them. So I think as a pediatrician, as an oncologist, as a general practitioner, there are many points where you can have an intervention and have that educational opportunity to talk about organ donation, end of life issues. And once you have those points in time, hopefully it becomes a continuous conversation in the home. And we do that as a preventative tool so that it becomes an easier transition when they're at their end of life. And it becomes a culture, or you accept it as a part of the culture. I'm going to talk to my child about this, about organ donation. I'm going to talk about my end of life issues and how it's promoted in the Catholic Church. You know, organ donation is promoted, and you want to have that discussion.
All right. So tonight's conversations are all very deep, and we all just want to thank you for kind of, talking about these kind of difficult topics at length. We really appreciate it. And I've personally learned a lot. I'm sure our other guests have too. I wanted to end tonight's panel on more of on a lighter note, so we don't get kept up tonight by kind of the harrowing things we've heard today. I know I'll think about Dr. Davide cracking somebody's ribs tonight before I go to bed, so thank you for that. But to the last question, I wanted to ask you guys, how would you approach a Filipino patient who comes in to talk about inaccurate medical information that they find on Facebook or other social media, influencing them not to take their medications? The asker, she's experienced a few patients like that, as well as their own parents. And oftentimes they'll choose not to take their meds because they're afraid it'll worsen their health. And I'm sure we've all had that experience with COVID and like the viral remedy of eating like garlic cloves to prevent, I guess, the viral pneumonia. So I think this would be a good discussion to end tonight on.
I think me and Gary are excited about this because pediatrics, right? Filipino parents absolutely want to take care of the health of their children. So whenever we prescribe medicines for kids, the Filipino parents are pretty much on it. They will do everything that you say. Is that what you're going to say, Gary? So we don't have this problem. No.
Maybe. So there are some parents. Well, you know, the best we can talk about here is vaccine hesitancy, right? So you try to dispel the myths. I've come, you know, as my Philippine Medical Association board will attest, there's a lot of interesting things that are going around regarding the vaccine. Obviously, they're spread by people who are against the vaccine, or they're just myths or lies, or, you know, I've had already people calling me, asking me questions about that. And, you know, you try not to just tell them you're, you know, well, that's dumb. Well, that's stupid. You know, you don't do that. Obviously, you're just going to make them upset and they go away. You address their concerns. And this isn't just Filipino, this is everybody. Yeah. You speak about what they're concerned about. You ask them what makes you concerned about it, and you do your best, because you still, when you guys are all doctors or in higher positions, you are still an authority that they're going to ask questions to. So you do your best to try to explain your reasoning, and you hope for the best. That's my experience. You hope for the best. You can't twist somebody's arm, and just go from there. And if they don't want to take their antibiotics, well, you know, they're only going to come see it like the following week when they're not better, right? So and when they're not better, then you can just kind of tell them, well, we tried your way, now we can try ours.
Yeah, I think that's an especially, you know, kind of daunting challenge, I think, right now, because there's so much disinformation. And so it's not just, you know, people with poor, you know, or lower levels of education. I mean, if these are people who have doctorates and, you know, feeling, you know, kind of caught in the whole confusion aspects of all this. So, you know, I don't think that's a unique, you know, issue to the, you know, Filipino community for sure. I don't know, you know, I mean, I don't think, you know, our government is sort of grappling with that as well. I mean, how do you deal with all this misinformation that's out there? And there's a lot of information that's out there, you know, through social media. So we try our best, and, you know, I think we try to emphasize evidence-based. Look, you know, we're dealing with like really strong, tough medications that can potentially be, you know, threatening to your life, and we have to adhere to the best, you know, guidelines and the best evidence that we have, you know, the best that science has, and we can't really, you know, detract too far from there. So that's, I try to go back to the whole science part of it, and how it applies. But again, you're not going to convince everybody.
Oh, and so again, make a deal with your patient. If you don't like what you're taking and they're adamant to take it, be like, and you're kind of scared that they're taking that medication. Like for instance, my cancer patients, they don't want chemo. They're gonna take Sarsop, Gayabano, or whatever, which actually helps. But again, you know, I say, okay, let's come back in 3 to 4 months and see how you're doing to see if that helps, right? Because and I also, you know, do frequent scans and stuff on the patient. So let's see if it's working, right? So that way, again, you're accepting that you're doing it. You're kind of okay with it, but they know you're not okay with it, but you made a deal. And because you're following over time and you care how the outcomes are, then, you know, they may change or you might be surprised that they're actually doing okay, right? So, but you keep that relationship there and you're still on the side of the patient.
I would love to suggest one more thing. Hazel, this was amazing. And this is so like, I don't know, inspiring to just have all these young people participate in all this. So, you know, word to the PMAH, just keep up with the work. And, you know, I look forward to additional, you know, additional collaborations like this. This is like amazing. So I look forward to, you know, melding all these, you know, different, you know, kind of non-docs and, you know, whatever. This is amazing. I think we should do some more of these. I think only good will result from it. So I really laud you guys for doing this.
Thank you, Hazel. This is awesome. Thank you.
Don't thank me. It's all of the MS1s. So we should really be thanking the MS1s who came up with this idea. They asked for it, actually, Dr. Palalay. And so we just responded. So thank them. So thank you, MS1. Thanks, PMSAH.
And I think the more you guys as medical students hear stuff like this early on, even before your clinicals, you'll be more aware of it when you hit seeing patients and people. So that way you're actually becoming stronger doctors right now. So I encourage you, if you have any of these ideas again, because this is great, this is awesome. And you know, and you hear it again and again and be like, oh yeah, we talked about that. So you guys are going to be stronger doctors than the rest of your peers, which is great. Good luck, everybody.
Thank you everyone for coming. I'm gonna figure out how to unpin everyone that I did. Okay. There we go. Yeah, thank you so much for your insight and for making time to talk with us today. It was really helpful. Okay.
You're welcome. Thank you.
Any last words from Austin or Dr. Abensai?
No, I have nothing else to say except thank you so much, PMSAH. We look forward to having the MS1s become MS2s, the MS3s on the call becoming MS4s, and welcoming the new incoming class very soon. As Arlene said, long live PMSAH.
And if there's any pre-meds or med students, anyone can use mentorship on the call. Like Dr. Abensai said in the chat, feel free to reach out to like anyone on this call. Like we talked about, Filipinos are all about community, so we're all willing to help you get through this journey of medicine together.
Yeah, so Dr. Dela Cruz and I, we're pediatrics. My husband is critical care, Dr. Palalay is Hema, Dr. Vera is surgery, Dr. Davide is family medicine, Dr. May Rose de la Cruz is public health. And you know, there's so much integration between medicine and public health. It's a great partnership. So if any of you outside of, you know, if you're in JABSOM and you just want to have like extra mentorship on the side in any of these fields or any other field, we at PMAH have doctors of all specialties. If you want to be connected with a Filipino doctor that does what you might want to do, please reach out. We're more than happy to help connect you.
And we'll send out an email from the PMSAH email with like everyone's email and like some of the additional answers to the questions that we didn't get to.
Good luck on MCAT.
Thank you. Have a good night, everyone. Bye.
Salamat.
Thank you.
Thank you. Good night.
Good night, all.